Hi, this is Brian Kim. I'm going to share with you case number 15 in the best way to do cataract surgery series. This is a small pupil with a 2 to 3 plus density, and I'm going to show you confident mechanical fracturing, double chop, cross chop, despite poor visibility, making sure I'm in the central safe zone, using mechanical fracturing to crush the lens pieces, and reducing CDE, but also being able to do this case without very good visibility. I use my corneal marker to help me center and size my rexus. I make my 2 paracenteses incisions and then inject intracameral lidocaine and epinephrine. I inject dispersive viscoelastic, make my triplanar corneal incision. I make a vertical groove and then tunnel and then enter the anterior chamber. I do my puncture style capsulorhexis. I puncture with the forceps, pull down and sweep a little bit to the right to create a little bit of a C-shaped flap. And then I grab and re-grab intermittently, following the contour where I did my corneal marks to help me get a good central and sized capsulorhexis. I burp some viscoelastic out of the eye and do my capsular fornix hydrodissection. I place the cannula out to the equator, point it down towards the nerve, and get a nice fluid wave. I decompress on the left side and then begin to spin the lens from the right side. You can see it spin nicely. I lift the main incision with the chopper and enter the eye without irrigation to minimize any Descemet's trauma. I remove the surface epinuclear material, and then I perform the double chop technique. I place the chopper out to the equator, place the phaco tip more vertically, subincisionally. I bring the instruments together and crush the lens material in between, and I'm able to fracture the lens completely in half. I then place the chopper out to the contralateral equator and perform the cross chop maneuver, crushing the right heminucleus. You can see I'm doing mechanical fracturing techniques, crushing the lens material between the chopper and the phaco tip into smaller sized pieces, and then crushing them in small pieces before emulsifying them using bursts of ultrasonic energy and vacuum. You can see I'm using successive forces, mechanical fracturing technique to crush the lenses into bite-sized pieces, and then emulsifying them with ultrasonic energy and vacuum. I'm always making sure that the chopper is underneath the epinuclear material when I go out into the equator. This ensures that I'm not going to catch the capsular bag or the zonules. Again, I'm going under the epinuclear material. I go around the entire thickness of the lens, place the phaco tip deep, and then crush the lens material in half completely. I then start to crack the lens material to make sure that there's complete separation. If the lens doesn't try to come out of the bag very easily using the vacuum, I just pull the lens out using the chopper. I pull it to the central safe zone and then crush the lens intermittently as well. You can see this is a fairly dense lens. I'm having to use careful pulses of ultrasonic energy and vacuum using mechanical fracturing forces to chop the lens into smaller bite-sized pieces. All the action is in the central safe zone away from the iris, and you don't see me ever getting close to the iris and snagging the iris despite the small pupil. Again, this lens is very sticky. It's a dense lens. If I try to grab the lens just using ultrasonic energy and vacuum, I might struggle to prolapse the pieces out of the bag. But because I'm using the chopper to pull pieces out of the bag, this is a very easy, no fuss technique, and I'm able to consistently pull the lens pieces out of the bag without worrying of doing any dangerous maneuvers. You can see the chopper is able to hook and maneuver and pull the lens pieces out of the bag very easily, just using mechanical fracturing forces to crush the lens pieces into smaller pieces, and then using ultrasonic energy and vacuum to pulse and remove the lens pieces completely. Once the endonucleus is completely out, I remove the epinuclear material, and I'm going to start at the edge and then try to place the chopper deeper, making sure that the posterior capsule doesn't come more anteriorly. Again, I'm trying to grab the edges of the epinuclear material, making sure that the posterior capsule is safe. I'm using the chopper to retract the pupil edge so I can see the epinuclear material up at the level of the anterior capsule. I push BSS into the eye and pull the phaco tip out and then the INA tip in. This is my fluid exchange. I'm starting subincisionally and I'm removing the cortical material. I'm going circumferentially around, peeling from the anterior surface first so they get a clean cortical cleanup. You can see I'm just using very careful amounts of vacuum and aspiration to tease and peel off the cortical material. In cases like this, when you have very poor visibility, you don't want to use aggressive fluidics. You might grab the capsular bag and then pull on the zonules accidentally. So I do like to switch to the polish mode fairly early in these cases when I don't have good visibility of the port because of the small pupil. So I'm using the polish mode and going around polishing underneath the anterior capsule edge. I'm also going to pulse BSS into the subincisional capsular fornix. You can see that there was a bunch of cortical material that came rushing out. So this gave me confidence. I got all of the cortical material out. I pulled the BSS cannula out and then inject cohesive viscoelastic into the capsular bag. I'm polishing and doing my sweep of the left side and then the right side. I'm injecting the single piece acrylic lens in the capsular bag. And then I'm going to use the Maltzman to help me visualize to make sure I'm completely in the bag. In these cases, in all of my cases, I like to rotate the lens 90 degrees clockwise, and I push the lens and tilt it in such a way that I'm sure that the lens, including the haptics, are pushed into the capsular fornix. And when I tilt it, I'm able to make sure I evacuate all the viscoelastic between the posterior capsule and the lens. I'm going to evacuate all the viscoelastic in the anterior chamber and then use a Maltzman to retract the pupil first on the right side and then on the left side, ensuring that both haptics are completely in the bag. I'm going to use the INA to remove all the viscoelastic in the anterior chamber, and then I'm going to push BSS into the eye and hydrate my incisions. So again, I'm able to show that with even small pupils, not just the soft lenses, but even the dense lenses, the 2 to 3 plus dense lenses, you can leverage mechanical fracturing techniques and able to prolapse lens pieces out of the bag, crush them into small pieces using mechanical fracturing techniques, have a very low CDE, and confidently and safely pull the lens pieces out of the bag without worrying about grabbing the posterior capsule or the zonules. Some surgeons are afraid of placing instruments into the capsular fornix, but I believe this is the single most powerful way and most efficient way to pull pieces out of the bag, especially in cases of small pupils or poor visibility. So I hope this was helpful to you, and thank you for your attention.